Welcome, everyone. We're doing a focused discussion today on biomaterials, really essential stuff for your plastic surgery board exams.
Absolutely. We'll try and cover the key classifications, properties, and uses you'll likely encounter, trying to keep it concise but comprehensive.
Okay, let's jump right in. Biomaterials, they can be synthetic or, naturally derived. We use them for replacement, reconstruction, augmentation.
And the absolute cornerstone, clinically speaking, is achieving long-term biocompatibility. That interaction with the host tissue is paramount.
Exactly. Ideally, what are we looking for? Biocompatible, chemically inert, non-allergenic, non-carcinogenic,
Yeah.
sterilizable, cost-effective, easy to work with.
That's the checklist. But the reality is often more complex. The host-implant interaction isn't always perfect, is that you get biological responses.
Right, and those responses can be anything from outright rejection or, say, fibrous encapsulation to resorption or, ideally, proper integration.
For this review, let's focus on the four main buckets: autograft, allograft, xenograft, and alloplast. That should cover most bases.
Good plan. Starting with skin substitutes. Autografts, taking skin from the patient themselves, that's kind of the gold standard, right, for permanent replacement.
It really is. Tolerance, integration, excellent. The big limitation, though, is always donor site availability. You only have so much skin.
Okay, so within autografts, we have split-thickness skin grafts,
Mhm.
STSGs. These include the epidermis and a variable amount of the dermis.
And you need to know those stages of STSG take. First is imbibition. That's the first day or two.
Then inosculation, sort of linking up the vessels around 48 to 72 hours.
And finally, proper revascularization kicks in around days 4 to 6. Getting that timeline down is important for understanding graft survival.
And these STSGs come in different thicknesses, right? Thin, medium, thick, depending on how much dermis you take.
Correct. Donor sites, usually thigh, buttock, back, maybe scalp or arm. The advantages are pretty clear. High survival rates, they revascularize quickly.
You can sometimes reharvest the donor site later, and you often keep the hair follicles there, too.
But the downside, and it's a big one, is secondary contracture. Thinner grafts tend to contract more.
Yeah, and the color and texture match can sometimes be, well, less than ideal compared to the surrounding skin. Definitely a consideration.
Then you have full-thickness skin grafts, FTSGs, epidermis, and all the dermis.
Key difference.
Yeah.
The dermis doesn't regenerate at the donor site, so you've got to close that primarily.
Donor sites are different too. Preauricular, postauricular, supraclavicular, groin, axilla, places where you can get primary closure more easily.
The pros for FTSGs: less contracture compared to STSGs, usually a better color and texture match, maybe better sensory return eventually.
But the trade-off is they don't survive quite as readily, revascularization is slower, and again, that need for primary donor site closure. So it's a balance.
What if you're really short on autologous skin, like in massive burns?
That's where cultured epidermal autografts, CEAs, come in. You take a small biopsy, grow the patient's keratinocytes in the lab.
So the big advantage is expanding coverage from a tiny donor site.
Exactly. But they're expensive, take time to grow, there's a potential immunogenic reaction from the culture stuff, and they're quite fragile, delicate sheets.
Epicel is the main product name you hear, right? For those really extensive burns, over 30% TBSA.
That's the one. Now, moving beyond autografts, allografts and xenografts.
Allo means same species, so cadaveric or maybe neonatal donors. Xeno means different species. Bovine, porcine are common.
And these can be just dermal or bilayered to mimic dermis and epidermis. Critically, they can be acellular or cellular. Acellular means no living cells, which helps reduce the immune response.
Let's talk about a cellular dermal matrix, ADM. It's basically the non-living scaffold of the dermis, collagen, elastin, chags.
Right. It acts as a framework for the host tissue to grow into. It doesn't replace skin itself, more reinforces soft tissue or helps wound healing. Incorporation takes maybe 1 to 2 weeks.
Clinically, where do we see ADMs used? Breast reconstruction is a big one for support, implant coverage.
Yeah, though you need to be aware of things like potentially increased seroma risk or that phenomenon called red breast syndrome.
Also, abdominal wall reconstruction, hernia repairs, especially in potentially contaminated fields where synthetics might be less ideal.
Definitely. Other uses pop up too. Chest wall, complex wounds as a bridge to grafting, head and neck like for mucosal defects, palate fistulas, even nasal contouring or eyelid work, and dural defects sometimes.
Okay, so within ADMs, you've got allogenic ones from human cadavers, decellularized. These fall under the HCTP regulatory pathway.
Alloderm is probably the most well-known. It needs rehydration, and remember, orientation matters dermal side towards the vascular bed, widely used in breast surgery. Early on, maybe less successful in the abdominal wall, but newer versions exist.
Like Alloderm ready to use.
Exactly, faster prep. And there are others: Dermamatrix, Flex HD, Graft Jacket, Dermacell, Represa, Dermaspan, Alamax, each with slightly different processing or claimed benefits.
Then there are these intergenic ADMs, porcine or bovine source. These are regulated differently as medical devices, often needing 510K clearance.
And the processing can be quite different here. Cross-linking is a key factor. It can make the material stronger, last longer, maybe less antigenic, but it can also slow down host tissue incorporation, potentially lead to more inflammation, maybe bowel adhesions in abdominal use, or even increase infection risk. It's a significant trade-off you need to understand.
So examples of xenografts.
Yep. Well, there's Surgis's biodesign that's non-cross-linked porcine, small intestinal submucosa, actually not dermis, used a lot in hernia repair. Oasis similar, non-cross-linked porcine SIS, more for wound healing.
Tutopatch is bovine pericardium non-cross-linked. Permacol is cross-linked porcine dermis, often for abdominal wall.
Veritas is non-cross-linked bovine pericardium. Colomen was cross-linked porcine, but had some reports of higher infection rates. Surgimen, non-cross-linked bovine. Stratus, non-cross-linked porcine, used in breast and abdominal wall. Zenmatrix is another non-cross-linked porcine option, though it had a recall history worth noting.
Okay, that covers the ADMs. What about a cellular bilayered matrices?
These try to mimic both dermis and epidermis, usually a dermal layer for ingrowth, often collagen-based, and then a synthetic top layer, like silicone, acting as a temporary epidermis or barrier.
So tissue regeneration or temporary wound dressing.
Pretty much. Integra dermal regeneration template is the classic example. Bovine collagen matrix with a silicone outer layer. Takes time for neovascularization, maybe 2-3 weeks. Then you remove the silicone and put a very thin STSG on top.
Advantages being you might get away with a thinner STSG, and it creates a vascular bed over tricky structures like bone or tendon.
Correct, but it's expensive, and it's inherently a two-stage procedure used a lot in burns, fracture releases.
There are variations too, right? Meshed Integra, single-layer versions.
Yes. And then there's BioBrain that's different, more of a temporary dressing, porcine collagen, nylon mesh, silicone layer, usually removed after a week or two. Good for temporary burn coverage.
What about matrices with actual cells in them?
Right, the cellular ones. Dermagraft is a cellular dermal matrix. It has neonatal fibroblasts grown on a polygalactin scaffold, indicated for diabetic foot ulcers.
And cellular bilayered matrices.
These aim to be more biologically active, closer to real skin. Apligraf and Orcell both use neonatal fibroblasts and keratinocytes on a bovine collagen matrix. They have a short shelf life, used for venous ulcers, diabetic foot ulcers. Orcell is cryopreserved and also has a burn indication.
And Transite.
That one uses neonatal fibroblasts cultured on a BioBrain scaffold. It's mainly for temporary coverage of deep, partial thickness burns after excision.
Okay, quite a range of skin substitutes. Let's shift gears to bone substitutes.
Yeah, clinically, we're mostly dealing with autologous, allogenic, or synthetic bone grafts. Xenografts are less common here.
And bone graft incorporation follows the standard stages of bone healing, doesn't it? Hematoma, inflammation, vascular, and growth.
Then resorption of the graft material and deposition of new host bone. The key biologic properties to remember are osteogenesis, osteoinduction, and osteoconduction.
So osteogenesis is bone formation by the graft cells themselves, the osteoblasts within it.
Osteoinduction is stimulation of host bone formation, usually by growth factors like BMPs present in the graft.
And osteoconduction is just the graft acting as a passive scaffold for host bone cells to grow onto and through.
Exactly. Now, bone autograft, taking bone from the patient, is the only one that reliably has all three properties: osteogenesis, osteoinduction, and osteoconduction.
Which is why it generally incorporates so well. Downside, obviously, is you need a donor site.
Autografts can be cancellous or cortical. Cancellous bone, like from the iliac crest or metaphyses, is packed with osteoblasts and growth factors. It heals mainly by osteogenesis.
Revascularizes quickly, maybe within a couple of weeks.
Yeah, but it offers very little immediate structural support. Good for filling small gaps or non-unions where you don't need instant rigidity.
Cortical bone, on the other hand, from the fibula, radius, iliac crest, calvarium, maybe rib.
Right. Remember to remove the cartilage cap from rib grafts to prevent resorption issues. Cortical bone is much less biologically active initially. It heals mainly by osteoconduction.
But its big advantage is immediate structural support and maintaining volume. Takes longer to revascularize, though, maybe a couple of months.
So you'd use it for larger segmental defects, say over 5 centimeters, where you need that immediate strength.
Okay, what about bone allografts? Cadaveric bone.
These are processed, which unfortunately reduces or eliminates the osteogenic and osteoinductive potential. So they're primarily osteoconductive scaffolds.
And union takes much longer, potentially a year or two.
Yeah. They come as fresh frozen, retains a bit more strength, maybe slightly more immunogenic or freeze-dried, also called lyophilized. Freeze-dried has lower infection and immunogenicity risk, easier storage.
And then the synthetic bone substitutes the alloplasts.
These are basically just osteoconductive, maybe with some minor inductive properties depending on the formulation, but little to no osteogenesis, and they have variable resorption rates.
Calcium sulfate plaster of Paris was an early one. Fills voids, resorbs pretty quickly, 5 to 8 weeks.
It's generally safe, well-tolerated, can even be used in infected sites, but it's weak mechanically and needs a dry environment. Good for augmenting autografts or filling voids after debriding osteomyelitis. Osteocet is a product name.
Calcium phosphates are another big group. Better compressive strength than sulfate, but still brittle. Highly inert, resorption is often limited or very slow.
They do well in the craniofacial skeleton, seem less prone to infection there. Good for metaphyseal defects, craniofacial reconstruction, even soft tissue filling sometimes.
Within calcium phosphates, there's hydroxyapatite, HA. That's the main mineral in natural bone.
It comes in different forms. Ceramic HA, like calcitite, is basically permanent, very slow resorption. Coralline HA, like perosteon, derived from coral, is porous, allowing some ingrowth.
And cementable HA pastes, like Bone Source or Norian SRS.
Right, they set isothermally, good for contouring or resurfacing. Then there's beta-tricalcium phosphate, PTCP. Its resorption is more unpredictable, maybe 6 to 18 months. Products like Vidos or Orthograft.
Lastly, among synthetics, methyl methacrylate, MMA, bone cement.
Yeah, totally non-resorbable polymer. It's inexpensive, moldable, inert, once set, strong. You can impregnate it with antibiotics.
The mixing is exothermic, which can damage tissue.
Yeah.
And it's dense, doesn't allow any bony ingrowth. It just gets encapsulated by fibrous tissue.
So applications are things like cranial reconstruction, maybe forehead augmentation, fixing joint replacements, filling voids after tumor removal where you don't expect bone integration.
Got it. Briefly, cartilage substitutes.
Autografts are king here too, usually from nasal septum, ear concha, or rib cartilage.
Why are they good?
Well, cartilage is a vascular, dense matrix, low metabolic rate. Autografts tend to resorb very little, hold their shape well, you can sculpt them, and they rarely get infected.
Disadvantages. That dense matrix means host tissue doesn't really grow into it. And rib cartilage, especially, has a tendency to warp over time.
Applications are mostly facial reconstruction, nose, ear, eyelid support, sometimes nipple reconstruction.
And cartilage allografts. Cadaveric cartilage.
More problematic. Potential for ossification, calcification, higher resorption rates, higher infection rates compared to autografts, generally less preferred if autograft is available.
Okay, last big category. Miscellaneous alloplastic materials. Let's start with metals.
Used a lot for plates, screws, fixation, high tensile and compressive strength. Stainless steel is a common alloy, very strong.
Downsides are potential corrosion, nickel allergy in some patients, and significant artifact on CT and MRI scans.
Vitalium is another alloy, cobalt, chromium, molybdenum. Corrosion resistant, strong, maybe less scattered than steel, but it can be harder to contour.
Titanium is often favored now, isn't it? Pure metal or alloys.
Yeah, it's strong but lighter, very corrosion resistant, allows for some fibroosseous ingrowth, which is great. Low radiographic scatter, relatively easy to contour. Used widely for mesh, plates, screws, especially craniofacial.
And gold.
Main use is eyelid waiting for legophthalmos. It's corrosion resistant but expensive and quite soft.
Moving to polymers. These are synthetic materials, long repeating molecular units. Porosity varies a lot.
Right, you can have macroporous, large pores allowing tissue ingrowth, microporous, small pores, maybe allowing fluid passage but limiting cell ingrowth, or non-porous.
Let's cover non-resorbable polymers first. MedPore is high-density polymer.
So you get significant tissue ingrowth, which makes it stable but also really difficult to remove if needed. Comes as sheets, blocks, preformed implants. Used for facial augmentation, orbital floor reconstruction, ear reconstruction.
Gore-Tex is expanded polytetrafluoroethylene EPTFE. That's microporous.
Comes as sheets, tubes, blocks. Used for facial augmentation, sometimes chest or abdominal wall patches, vascular grafts, facial slings. Gore Dual Mesh is a specific EPTFE product for hernia repair, with one smooth side to face the viscera.
What about meshes like Marlex or Prolene?
That's polypropylene. Macroporous, considered a heavyweight mesh, very common for chest and abdominal wall repairs, though it can incite a significant foreign body reaction and potentially adhere to bowel.
Merceline.
That's polyethylene terephthalate PET, a mesh with some microporous components also used for hernia repair.
Okay, now resorbable polymers.
These break down over time variable rates, can sometimes cause inflammation as they degrade. Dexin mesh, polyglycolic acid, and Vicryl mesh, polyglyctin 910 are common examples.
They lose strength relatively quickly, maybe 4 to 6 weeks, often favored in contaminated fields because they eventually disappear. Also used as suture materials, of course.
Tiger mesh is interesting. It's designed for long-term resorption with dual-stage mechanics. Has two types of fibers that resorb at different rates. Provides strength for about 6 months, fully resorbed by 3 years, used for soft tissue reinforcement.
And resorbable plating systems, like Lactosorb.
Right, that's a copolymer of polylactic acid and polyglycolic acid, used mainly for pediatric craniofacial fixation where you don't want permanent plates hindering growth. Loses most strength by 8 weeks, gone in about a year.
What about composite meshes, combining materials?
Mostly for ventral hernia repair, often called tissue-separating meshes. The idea is to have one side that encourages tissue ingrowth into the abdominal wall and another side that's less likely to adhere to the bowel.
So maybe a non-resorbable layer like polypropylene facing the fascia, and a resorbable or barrier layer like oxidized cellulose or collagen facing the viscera.
Exactly. Orientation is critical with these. Examples include Proceed, Sepramesh, Peritex.
And coated meshes.
These are synthetic meshes coated, usually on both sides, with some kind of low-inflammatory material. C-Core coats polypropylene with omega-3 fatty acids. Tymesh coats polypropylene with a thin layer of titanium. The aim is to reduce adhesions and inflammation.
Last one, silicone.
A non-resorbable polymer based on silicone, comes as liquid, gel, or solid elastomers. Injectable liquid silicone is not FDA approved for cosmetic use due to risks like migration and granulomas or siliconemas.
But the solid or gel forms are widely used. They're generally inert, resist degradation, easily sterilized. The old concerns about systemic disease have largely been refuted by large studies.
The main drawback is that it's non-porous. No tissue ingrowth. The body just forms a smooth, fibrous capsule around it.
Clinical uses. Obviously, breast implants, both the shell and the filler, gel or saline. Also used for other soft tissue augmentation implants, chin, cheek, joint replacements, tendon reconstruction components.
Phew, okay. So, to quickly recap, we've covered the main biomaterial categories you'll encounter: skin substitutes, bone grafts and substitutes, cartilage grafts, and a whole range of alloplastic materials like metals and polymers.
And hopefully highlighted the key properties, advantages, disadvantages, and common clinical applications for each. Understanding these is absolutely fundamental for your board exams and, more importantly, for safe and effective clinical practice.
Definitely. And remember, this field is constantly evolving. New materials, modifications, long-term data. It's crucial to keep learning and critically evaluating what's available to choose the best option for each specific patient and situation.